Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan.
I'm Joe Steckler. Welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is sleep apnea and dentistry before cancer treatment. And with me in the studio is Dr. Lee Sheldon of Solid Bite Dental Implants. Welcome, Lee.
Thanks. Good to be here, Joe.
Good. We use each other's first names. You're a doctor, but we have been doing these shows and our radio shows. When I go to you and when you have your pink scrubs on and I sit in a chair and you start grinding on my teeth, you're my doctor.
All right. Well, but here I'm Lee.
Here
I'm Lee.
Yeah, here you are a doctor who is my friend.
Yes.
But Dr. Sheldon, it has been a great pleasure for me to have you on so many different shows that connect the teeth and the gums and the jaw and the head to the rest of the body.
Yeah, and it's been my pleasure too.
You know, an area of medicine, medical treatment, we don't really talk a lot about is sleep apnea.
It's true. Yet sleep apnea has become popular over the past 15, 20 years. We didn't think about sleep apnea before that time. You know, we used to say, oh, well, he kind of chokes when he's snoring, or something along that line. Yet we found so many people who were suffering from daytime sleepiness that a certain amount of research was done and found out that, in fact, it was related to how you sleep at night, or more importantly, how you don't sleep
at night. Yeah.
Because the fact is that we've got this airway. This airway is held open by muscles. And just like our muscles become flabby in other parts of our body, the muscles that hold open this airway start to collapse as well. Now, when they collapse like this, there may be a little bit of vibration. We call that snoring when we breathe in and out. But if the muscles collapse totally, that's sleep apnea. Apnea meaning no breath at all.
That's what apnea means?
That's what apnea means. So if there's a problem, how do you notice there's a problem? First of all, the spouse will often tell you there's a problem. I hear him, and it's usually a him, but sometimes a her, stop breathing at night. Now, sometimes we don't even know how often we do stop breathing at night. But certain things develop as a result. So there's the daytime sleepiness problem. You wake up and you don't feel refreshed at all. And that may seem like a minor problem. But if you look at how that relates to more serious diseases like heart attack and stroke, particularly if you already have hypertension, it can be a major exacerbator, if you will. Something that can really cause that heart attack or stroke to come about. Recently, we've seen development in increased cholesterol, increased levels of diabetes as a result of having sleep apnea. So it is a significant problem.
How in the world could having sleep apnea cause your cholesterol to go up?
That's a good question. I don't know the answer to that question. But the research has been done and has shown a relationship. So what happens? You see your physician. The physician refers you to a sleep apnea specialist, who is usually a pulmonologist, sometimes it will be a neurologist or an ear, nose, and throat person, but somebody who is taking the time to study sleep. And then you're given a test, it's called a polysomnogram. You go into a sleep lab, you have all these electrodes attached to you, and you have somebody monitoring those electrodes and monitoring your sleep. And I've been to sleep labs, they're very comfortable, except they've got all these wires on.
Did they do it to you?
I've had a home sleep apnea test. As a matter of fact, two done. I didn't do it in a sleep lab, I did it at home.
You talk so much, it's impossible for you to sleep during the day.
You're right. but the fact is that I have had the test done, and I've seen the test being done. And what it will monitor is the number of apneic episodes that you have per minute and per hour. And so you can, if you have 5 or fewer, then you don't have sleep apnea. If you have 5 to 15, you have slight sleep apnea. If you have 15 to 25, you have moderate sleep apnea. If you have more than 25, then you have severe sleep apnea. These are episodes of stopping breathing while you're sleeping.
Okay. If men, sleep apnea affects men more than it does women.
Yes.
Would it affect men that are large in size more often than it would somebody was moderate or small?
Yes. In 40% of the people who have sleep apnea, we can relate weight to it. But 60% we can't.
Almost everybody I know that has sleep apnea have been overweight.
Yeah, but it's only 40%. So there's still a large category of people who have sleep apnea who aren't overweight at all. But there are people who, when they lose weight, their sleep apnea goes away. So there is a strong relationship, at least in that group. And the 40% could be 60%. It depends upon who's doing the measurements. But it's not everybody.
Okay.
So now, what do? I mean, first of all, you want to wake up refreshed during the day. And so what has been prescribed commonly is some kind of positive airway pressure. It's called CPAP. It's some way of a machine breathing for you to keep that airway open. So essentially you have air that's being forced into your mouth or into your nose to keep that airway open.
And you wear a big mask over your face.
Yeah, and the masks have become smaller and more comfortable, but you do wear a mask over your face. And it's tethered with a tube that's attached to a machine, and that machine essentially is a pump to pump air into your mouth or into your nose.
And I did a radio show on this once, and the sleep apneaists, they have a special name for these people that do that. I can't remember what it is. But all told, there are a range of about 30 masks that can fit over the face. And depending on your face structure, they fit these masks to you.
That's right.
But I've never had anybody that I've been aware of that wore the mask that was comfortable wearing a mask.
Yeah, about 50% of the people do wear the mask and they do okay. But there's a whole other 50% that don't and can't. And so the mask, the CPAP, is, according to the American Academy of Sleep Medicine, that is the #1 recommended treatment. And as long as you can wear that mask, that's going to work 100% of the time.
It's feeding oxygen to you.
Well, it's feeding air to you. It's not necessarily it's air. It's pumping air into your body.
Oh, okay. It's not oxygen then.
No. So it's just opening up the tube. It's essentially blowing something in to keep that airway tube open and to prevent it from collapsing.
So there's a little machine, and they're making them smaller now so people can take them with them on vacations and everything else.
Yeah, yeah.
But what do people wear that machine during the day too, or?
It's only for sleep.
Only for sleep.
Right.
Okay.
Right.
Only for sleep.
So then there's that second group, that 50% who can't wear it, and that's where a dentist can help.
That was what was interesting to me when you started telling. When I read in your book, The Ultimate Mouth Manual, there was a whole section in there on sleep apnea. Yeah. There's a test. I think you're going to give that to me.
I'm going to give you the test.
You're going to give me the test.
And I'm going to give you the test too.
Okay. Yeah, well, when Dr. Sheldon is giving me the test, right now, get yourself a pencil and paper so you can add the score up when he gives me this test. And as I'm talking, you just take a minute and get a pencil or a pen or something. I'm not going to ask you to remember all the numbers. I couldn't remember them either. I'm still making an Alzheimer's test out of it.
I'm about to give you the test, but I started a thought, and I want to complete that thought first, if it's okay with you.
Okay, go ahead.
And that is the second recommendation of CPAP doesn't work.
Let me hold this one.
Okay. The second recommendation is an appliance which keeps your airway open. And this is a dental appliance. So, Seth, just let me know how you're doing with this. And essentially, we're going to have this appliance. You see, there's one appliance that's worn on the upper and one appliance that's worn on the lower. It's removable. So you see, it comes off.
That is sort of like the thing I wear at night, folks.
It is.
For my TMJ.
But there's another half of the appliance that's down here that's removable as well. So let me show you how that works, and I'll try to keep this steady for the camera so we can see that. You know, when you take CPR, you're supposed to move the jaw forward in order to be able to open the airway. That's what this appliance does. You see this wing right here? There's a wing right here. This wing engages this plate right here and moves the jaw forward. Now, what we want to do is to gradually move the jaw forward until we reach the sweet spot, the spot where the airway is fully open as far as it can. And so there's this little screw right here, which I can't adjust it right now, but you adjust the screw in order to bring the jaw farther and farther out until your airway is open again.
So what the thing does, you adjust the two pieces of plastic, so we put them in the mouth, it just
That's correct.
makes your jaw come forward automatically.
That's right.
Okay.
And this screw, the screw tolerance is 1/10 of 1 millimeter. So you continually open the screw until you reach that point where your jaw is at the best position and you're not snoring and you're breathing correctly again. Then you go back to your pulmonologist, get another sleep test done, and see how you've done.
You know, honestly, when I heard you first talk about this, I thought your darn dentist was putting a screw in your jaw to make your mouth come forward. And I went, how in the world are you going to do that? I mean, there's a lot that you can accept. But
yeah. But this is nice. I mean, some people who use the CPAP, still they've got to carry that box with them if they're traveling. Well, there's some people who will just use their regular CPAP at home and then bring one of these appliances on the road with them.
Okay, let me ask you a question.
Yeah.
When this thing makes the jaw come open, does that make the airway come open so the breath through the nose goes?
Yes. It'll bring
it's not through the mouth.
Well, it can be through the mouth or through the nose, depending upon how you're breathing. But it will open the entire airway by bringing the jaw forward. Yes.
Okay. That will open the airway.
Yep. And that's the second recommendation. If CPAP doesn't work, that's the next thing that would be used.
Why in the world why wouldn't they try this before they try the CPAP?
Because this is not 100% effective. This is only about 70% effective.
Okay.
So you rather go with 100% first, and then if that doesn't work, then go to the next.
Okay. If you can't do the other, this is a fallback position.
That's right.
Okay.
Okay. So now you want to take the test?
You want to give me the test? Okay.
Okay. Let's take the test. So this is called the.
I'll do it honestly too.
Yeah, and you do it honestly too.
Well, I am. You're going to give it to me. I'm going to do it honestly. Well, you should be honest. You wrote the book. You're just going to read. Don't change what you put in there.
Okay. So this is called the Epworth Sleepiness Scale.
Okay.
It is one of the popular sleepiness scales that's used by physicians to check whether you have sleep apnea. And here's what I'm going to do. I'm going to ask you questions about being in a certain situation and whether you tend to go to sleep or not. And we're going to do it on a scale of 0 to 3. Okay? So 0 is no chance of sleeping, 1 is slight chance, 2 is moderate chance, and 3 is high chance of sleeping. You with me?
All right.
Okay?
Okay, you, the viewer, are going to 0, 1, 2, and 3, and write it down in your paper, and I'm going to do it here, and let's see. I don't know where I'm going to come out, so we'll see.
Okay, good. So the first one, I'm keeping track of you, right? I'm keeping your score. So here's the first situation. Sitting and reading. Do you have a no chance? That's 0. A slight chance, 1. Moderate chance, 2. High chance, 3.
3.
3.
It relaxes
high chance
me.
of dozing. Good. All right. Number 2 is watching TV. 0, 1, 2, or 3. No chance, slight, moderate, or severe.
I'd say slight, because I like to watch the news, and I do stay awake for that.
All right, that's a 1. Sitting inactive in a public place.
I'd say never, because I love to watch people. I really do like to watch people.
Good, that's a 0.
And if I went to sleep in a public place, I'd fall and I'd hurt myself. I won't do that. I'm not going to do it.
All right, how about being a passenger? Being a passenger in a motor vehicle for an hour or more. 0, 1, 2, or 3.
1. Slight.
Slight chance, okay. Lying down in the afternoon.
Never, I don't like. Are you talking about noontime or late afternoon?
Afternoon. I've got another one for noontime. This is afternoon. So I've got another one for right after eating, but this is afternoon. Your mid-afternoon siesta, 2, 3 o'clock, you just lie down, and maybe you're just doing a relax, but you always fall asleep.
Oh, I can fall asleep anytime, but I still have to say one. Really.
One? Okay, good.
The other times, if I want to go to sleep, I know I can.
Okay. How about sitting and talking to somebody?
Never, because I pay attention to what somebody says.
Very good. Sitting quietly after lunch, and you haven't had alcohol.
Slight
chance, so that's one. Okay. Stopped for a few minutes in traffic while driving. Talk about a dangerous situation. So when you're stopped in traffic, when there's a traffic jam or something like that, do you have no chance of falling asleep? 1, slight. 2, moderate. 3, severe.
I have to say 1 because I have dozed off. I have to admit it.
Okay. And that's it. So now add up your score. Add up your score at home. I'm going to add up Joe's score here. 4, 5, 6, 7, 8. You're doing very well. So your score is an 8. So let's talk about the significance of the scores. If you have a score of 10 or more, that's considered sleepy. If you have a score of 18 or more, that's considered to be very sleepy. But if you have a score of 10 or more in this test, you should at least get it checked out by a sleep specialist and make sure you're really doing okay.
Okay.
Okay?
I agree.
So how'd you do at home? And that'll determine whether you should be seeing a sleep specialist for evaluation or not. Now, the sleep specialist will do your evaluation for you. And then likely a CPAP, if you have sleep apnea, a CPAP will be fitted for you in the sleep lab. And so it's tested on you while you're asleep. And if that works, that's where you stay. If not, then you go to a dentist who knows how to work with a sleep apnea appliance, and you would have the dentist construct one for you.
Maybe, I didn't even think about asking this, is there any kind of a qualifier to what we're talking about now? Let's say, if a person wasn't well, would this test still apply?
Yes, it would.
It would?
Yeah, it would, because the test is only an indicator. It's only a screening device. Okay. Then the next step is for you to get the test done. Or the real polysomnogram. Go in the sleep lab and get that done, because if you're not well, that means you might have one of those major diseases. And by having sleep apnea on top of that major disease, it can result in a fatal event.
Lee, how significant really is sleep apnea as a danger to a person?
I think it is. I mean, it depends upon how sick you are generally. There's some people who just have sleep apnea, and it's more of a lifestyle problem. I mean, how would you like to go to sleep at 9 o'clock in the morning after you think you've slept well all night? And how good are you going to do at work? Or is it perhaps, particularly if you're in a major metropolitan area where this program might be shown, imagine driving in traffic and being sleepy, and you're yawning and you're fighting to keep awake. That can be a danger to you.
Is it the cause of the sleep apnea at night that deprives you of good sleep that causes you to sleep during the day?
Yes.
Okay.
Because when you have sleep apnea, what's going to happen is I'm going to act it out. So you're breathing. And then you stop breathing. And so you stop breathing, and depending on how long you stop breathing, what's happening to the oxygen that's going to your brain or to other parts of your body? It's going way, way down. And in the sleep test, they measure how much that oxygen is being reduced. It should be 95, 96, 98%, 99%, and sometimes I've seen it drop down as low as 70 and even lower than that.
Can it kill you?
That in and of itself, probably not. But increased episodes of that, yes. If you have hypertension and sleep apnea, you have 7 times the possibility of having a heart attack. That can kill you. So yes, it can. And what we want to do is to make sure that we're diagnosed properly so that we're treated properly and that we're treated early in order to prevent some of these events from occurring.
So in a nutshell then, it seems that almost the most significant risk of continued inattention to see if you have sleep apnea, and if you do, how great it is, you run the risk of a heart attack, stroke. Those 2, or what else? Yeah,
cholesterol and diabetes were the other 2. But even, let's assume that somebody has narcolepsy. Okay, that means they fall asleep during the day.
Right.
Well, we used to just say narcolepsy is a disease or a problem in and of itself. But Could the narcolepsy, falling asleep during the day, be as a result of not sleeping at night? You know, we depend on certain levels of sleep. There are different stages of sleep that we go through. One is the REM stage of sleep, rapid eye movement. And that's where we get the most rest. And that's where, by the way, we are totally paralyzed during REM sleep. Well, imagine never being able to get down into REM sleep, because when your muscles are paralyzed, your airway collapses. You're going to be exhausted during the day because you've never really gotten the proper rest. So while it's important for these critical life-threatening diseases, it's also important for those people who just aren't getting enough sleep and can't function well during the day.
So sleep apnea is something we should pay attention to.
Yeah, and it isn't just in the seniors group, it is in the younger group as well.
Yep. But it would become harder on a senior as the senior becomes more frail.
That's right. Absolutely.
So something to think about.
That's right.
The other thing that we did say, and we spent most of our time on sleep apnea, but let's talk a little bit about seeing a doctor before you have radiation treatment.
Yeah, particularly radiation treatment to the head and the neck. Because let's assume that you have throat cancer, you have cancer under your tongue or someplace in the oral cavity. Essentially, that means that if you're going to get radiation treatment, it means that the radiation beam is going to be directed to kill the cancer cells. That's important. But while it kills the cancer cells, it will kill some vital cells as well. Two areas that are important in the mouth is, number one, the salivary glands. If the beam is going through the salivary glands in order to be able to get to the cancer cell, it'll kill the salivary glands as well. And if that's the case, you'll end up with dry mouth, and dry mouth results in an acidic mouth, and an acidic mouth, teeth get decayed. So that's one side of it. The other side of it is that if radiation is going through the body, it's going through the blood vessels that affect the jaws, particularly the lower jaw, but the upper jaw as well. If you don't have a good blood supply to the jaw, then your ability to recover after a dental surgery, oral surgery, a tooth extraction, for example, is reduced significantly. And so prior to having the radiation therapy, you want to see a dentist for full examination. If there's a tooth or teeth that you've been trying to hold on to for a while, but now you're getting radiation therapy done, it's important to get those teeth extracted now, because if you should have a problem with a dental abscess, trapped infection, severe disease later on, you're at much more risk for a very severe jaw infection if you have your tooth extracted after the radiation therapy rather than before. The other thing is to be able to use some preventive measures. This is a great rinse. I'm not working for the company, but it's called Carry-Free, Carifree, which helps to prevent tooth decay. We want you to get on Carry-Free or something like that prior to the radiation therapy in order to be able to help prevent your teeth from decaying.
But it does, what that does is, I guess that would probably coat your mouth?
Oh, well, it actually is a liquid which stays in the mouth for a long time, and it changes that the acidity, and it neutralizes it in the mouth. It also has an artificial sugar, or actually it's a natural sugar called xylitol, and there is one sugar that's been shown to reverse tooth decay. It has that in it.
We're on the subject of radiation therapy and why you should see a doctor before, if you have a going cancer treatment. We talked about the effect of radiation therapy on the mouth, but how about chemotherapy?
Well, chemotherapy works a little bit differently, but the same effects occur. After all, with radiation therapy, we're directly killing the salivary glands and changing the blood supply. But if you're having chemotherapy done, that's an overall body type of treatment. But the same things can happen, particularly with reduction of salivary flow. You know, on other programs, we've talked about the fact that medications, there are over 500 medications that cause the mouth to be dry. The same thing can occur with chemotherapy as well. The mouth becomes dry. And this dry mouth really becomes a problem for seniors, because a dry mouth will produce an acidic mouth. An acidic mouth produces tooth decay. So it's really important prior to the chemotherapy, during the chemotherapy, and even after the chemotherapy, to make sure you're seeing your dentist on a more frequent basis, to make sure that if you have decay, it's caught early. But more importantly, to make sure that you're having those rinses and doing those things to your teeth that can help prevent them from decaying. It's far better to prevent a tooth from decaying than trying to treat a tooth afterwards.
Would it be fair to make an observation that, or what is your opinion about whether or not an oncologist would think to tell the patient to see the dentist?
Boy, you give me loaded questions.
I know, but it's a fair question.
It is a fair question. And I can tell you that most oncologists, I shouldn't say most, some oncologists, when they were in their training, at their cancer center where they did their training, referred to dentists, and dentists were part of the team in school. Does it happen as much on the outside? Probably not. And so it becomes important to you as a patient to make sure you ask the oncologist. You don't even have to ask the oncologist to get a dental checkup. Go get a dental checkup. I know you're concerned. Certainly you've got a problem and you're consumed by that problem. You want to make sure that cancer is treated and it goes away. But make sure you're doing the other things you can for yourself, particularly for your mouth. Because if your mouth becomes infected after chemotherapy or after radiation therapy, it's very difficult to treat.
The reason I'm asking the question because I've known two people that had throat cancer that had extreme radiation therapy to the extent that it truly burned their glands and their throat. And it's not an easy thing to talk about. It really isn't. It's a very serious subject. And it points out the need for seniors to be better informed about total body care.
Yeah. Just don't ignore everything else because you have this one thing going on. You have a life to live, and you're going to live that life as comfortably and as disease-free as possible. Just make sure all of the things you knew that you put in place, and I don't care whether it's nutrition or whether it's seeing the dentist or anything, make sure you're keeping those in place because you'll do better, and you'll heal better as a result.
Well, the other thing that I do know, and from my experience with people that are cancer patients, that nutrition is extremely important because so many of them lose their appetite and they don't want to eat as a result of the radiation, that they have to ingest foods that are going to contribute to the ability of their body to recover.
That's right. And there's lots of help out there for you as a cancer patient. Make sure you take advantage of that.
Okay. Any other comment about radiation and sleep apnea?
I think we've done it.
Okay. I thank you a whole lot for being here, Dr. Sheldon. And until our next series, we'll see what happens. And I want to thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL 1300 AM at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. Thank you for watching, and watch all the shows on our channels.